Next case, sorry, typo.
Math,
We're
not
gonna play
spelling.
a game here. Gentlemen, and Raffy, I need your help a lot here. You all have a white piece of paper, I think, and a marker. Is that correct? So each time you get some data, Joe, I can see that it's as big as what you're skilled with. Each time you get some data, I want you to write down what operation you're going to offer for this person. Rehab is not an option. If you get rehabbed, Sue, please delete them from the panel. So the consequences are real. Here you go. 18-year-old male plays football and baseball, and he's extremely competitive at both. Has a subluxation event, and gets treated non-optimally. Has a second instability event, and at this point says, listen, I'm going to go on to play college level sport. I will play baseball and I will play football in college. And now I've had, 1, 2, 3 instability events. Write down on your piece of paper and put it up in front of you what operation you will give him. Raph, can you see? I think someone's giving me the finger. All right.
Arthroscopic.
Just remember, you got it right backwards because the mirror's flipped on this thing.
Oh,
Brad says arthroscopic Bankart. Nick, hold it up a little higher. Arthroscopic stabilization. Scope. Butch is scope. And Brock is arthroscopic Bankart. And Joe, I can't see it. It gets faded out.
Mine says
everyone agrees to the scope.
Mine says Bankart, but most of my patients only play pickleball, so I'm not really sure what this football you speak of is.
Joe, please don't talk about your pickle. We're on the internet, my friend. All right, moving along. So look, he's a thrower, right? In addition to a football player. So let's go to the professional baseball doctor, Nick. What are you doing differently? Nuances for a thrower? Anything?
I'm not doing a remplissage. I think that probably is going to restrict his rotation. That's going to complicate things. I'm not opposed to going in the back. I just wouldn't go in the back to plicate. I go in the back and repair the labrum if the labral tear extends beyond 6 o'clock. Otherwise, I'm trying to just do an anatomic repair, and I'm avoiding an excessive capsular shift because, again, the kiss of death, assuming this is his throwing shoulder, the kiss of death is motion loss. If they lose any degree of external rotation, he's just not going to generate velocity on the ball.
So, Brad, you're trying not to pee, and you're asking a question. Before you ask your question, you have 2, and then I decide if you can ask. How long in a sling, and do you change your rehab, and when does he start rehab? That's 3.
No, it's the same rehab. 6 weeks in a sling. Start the rehab then. And
no rehab for 6 weeks.
Yep, no rehab for 6 weeks.
Anyone else?
Brad, that's really slow. Why do you go so slow?
Because I want it to heal.
Okay.
All right. I'm going to.
Can I ask Nick a question?
Yeah.
Yes, please.
So in the thrower, this guy's a thrower and a football player. For your arthroscopic Bankart, are you a mattress guy, like a double row mattress guy, not a bony Bankart, soft tissue, or are you a single cerclage suture, whether it's knotless or tied knots? Does it matter for your contact athlete versus your thrower?
The only reason why it may matter to me is I may use a knotted double loaded construct here because I can get 2 sutures for every point of fixation. And I would do those simple. I'm not a big fan of mattress. I think you could mattress with a simple around it, but I would use small anchors, all sutures, so I can get multiple anchors in the same real estate. And I'd use double loaded to give me more points of fixation per anchor.
So Nick, I agree with you 100%. In all of my collision athletes, my anterior inferior anchor is going to be a double loaded where I take 1 pinch from the back and 1 from the front, a little like Joe. But in a thrower, I don't take the pinch out of the back and double loaded. I stay simple up the front. I don't know if that makes sense. And truthfully, the number of throwers with instability events, at least in my hands, is pretty low. I don't know if you see more in your minor league and major league world. Yeah,
but I think, Paul, for me, what I try to do is I do the preparation the way that was shown in one of the videos earlier. And then what you can essentially do is you can pull the labrum up so you replace it anatomically, and that does your shift for you. So I don't try to take extensive capsule. I just try to shift the labrum back into its normal position, which is lateral and superior, and then take the labrum where it lies to allow me to essentially recension the capsule without plicating, so to speak. So I think if you do it anatomically, you're going to do fine. And, you know, to the point that I forgot who was just speaking about 6 weeks of, who said that they do 6 weeks?
Brad.
6 weeks.
Brad. It's
I mean,
forgettable.
these kids don't get stiff. They just don't get stiff. It's not a problem that we see in this population. So I think the error you make is taking too much capsule, and you do that by reproducing the anatomy instead of trying to plicate the capsule and get it bunched up.